Hi, I'm Dr. Neal Bhatia. I'm Director of Clinical Dermatology at Therapeutics Clinical Research in San Diego, California. Patients with superficial basal cell carcinoma have a lot of opportunities for treatment. Probably a few more alternatives than nodular or morpheoform or any other subtype, mainly because of again, maybe a little bit less risk, maybe a little bit more non-surgical friendly places like pre-tibial surface, on the body or on the trunk, maybe on the extremities. So when they're not a good surgical candidate for any other reason, maybe we're dealing with hemostasis problems, coagulation issues, oxygen, maybe they can't come into the office, maybe there's scarring issues, or honestly, maybe just surgical fatigue for someone who's had a lot of skin cancers. There's a lot of opportunities to use photodynamic therapy. Both blue and red light have data for superficial basal cell. We often use these areas depending on the area of treatment. And there's some good study data for both light sources, but also in combination with the Micromod 5% cream, which is, again, FDA approved for superficial. There's also, again, cryotherapy for those who may tolerate that better. Hedgehog inhibitors might be a little bit aggressive for one isolated tumor, but if the patient is a risk for many, or has Gorlin syndrome, or has extensive photodamage, we may think about the additive of hedgehog inhibitors for that patient as well. So a lot of options for working with surgery as a neoadjuvant or as an adjuvant treatment, as well as an alternative if the patient isn't a good surgical candidate by all decisions. Scar concerns are one of the biggest reasons why patients don't want surgery. And if they've had a history of keloids, if it's a cosmetically sensitive area, if they're concerned about the closure or the area that could potentially lead to a scar that would be significant for them, we have to really see what are their options and what is their interest in alternatives of either non-surgical alternatives for treatment, or depending on the surface area, maybe talk to them about efficacy and maybe the number of treatments necessary to either replace the efficacy of Mohs or surgery, depending on the location, or in fact, think about the opportunities to work in sequence, perhaps shrink the tumor burden first, potentially reduce the scarring from a surgical procedure, and then maintain the gains of no recurrence. So thinking in terms more of and instead of or is probably a better option for some of these patients when they just think I should either do A or B. I would probably talk to them about doing A and B. So personally, I'm a fan of where photodynamic therapy fits in any algorithm that involves photoaging, photodamage, actinic keratoses, and any kind of neoplasm, especially superficial basal cell. Mainly because I'm thinking about what's on the way. When PDT is in the algorithm, you have an opportunity to not only treat the tumor itself, but you can treat the surrounding innocent skin as well as the photodamaged skin that could potentially give rise to either AKs or more basal cell carcinomas in the area. So you can look at PDT as either the modality for the tumor, the modality for treating the photodamage, or the keratization change. Some might again like to call it that field keratization defect, or you can look at it both ways and incorporate it as a adjunct to whatever else is being treated with. Again, you can use PDT with hedgehog inhibitors, obviously with Mohs, do it before and after, do it in a sequence. But I think really the main message of PDT is just to do it, period.